Good afternoon, everybody, and thank you so much for joining our webinar today on quality improvement. We're just waiting for everyone to join and we'll get started in a few moments. Everyone will be placed on mute as they join, and we really encourage you to use the Q&A function for your questions. And just to say, the Q&A and the whole webinar is being recorded and will be made available to everybody that's signed up for today's webinar. Do put your questions on the Q&A as we go through today's webinar, and there will be a good chunk of time at the end for a panel debate as well. I think we're nearly ready to go, so I'm going to ask Andrew, our chair for today, to kick us off. Thank you.
Excellent. I think I'm off mute. Let me know if I'm not. Welcome, guys, to our webinar. My name is Andrew Cuff. I'm a consultant physiotherapist and work as a regional clinical lead for the North of England for Connect Health. Now, today's webinar is our 7th in the Connect Health Change series. So thank you to all of you for signing up and joining. And if you're watching this back at a later date, thank you for taking the time to do so. So far, we have covered a number of topics within our webinar series. These include FCP, artificial intelligence, persistent pain, COVID rehab, and IAPT. All of these are available on our website should you wish to catch up. But the focus of today is on quality improvement, particularly looking at quality improvement through the lens of knowledge creation, translation, and implementation. And for those of you that have read my accompanying blog on this topic ahead of today's webinar, will know that I am of the opinion that within healthcare, we should all be committed to continuous improvement, and as leaders within healthcare, that we are within the business of change. It's therefore a real pleasure to chair today's webinar, and I feel honoured to be able to converse with such an impressive panel. Recent months have once again taught us that the only constant thing in life is change. And as well as an importance of science, research and translation of knowledge into healthcare delivery to improve the quality of care and services provided. It's also taught us the value of hairdressers, and I'm hoping that I can pick up some QI principles today to apply at home to improve the quality of any future lockdown haircuts. Now, each presenter will speak for 7 minutes, followed by immediate 1 or 2 questions. But we'll take the majority of the questions at the end. So please do use the Q&A function to post your questions. So without further ado, our first speaker of the day is Professor Kay Stevenson, who is a consultant physiotherapist and honorary professor at Keele University in musculoskeletal care and leadership. Now, Kay will be talking to us today about translating knowledge from academia to clinical practice. But sadly, Kay has to dash off at 1 o'clock. So please use the Q&A function early, and we're going to spend a little bit more time after Kay's talk to put your questions to her so that she has the opportunity to answer them. So over to you, Kay.
Thank you so much, Andrew, and thanks everybody for the invitation today. It's great to be with you, and we've got a very rapid 7 minutes to try and get some of this information to you. So I hope over the next couple of slides I'm going to share some experiences with you, but there's contact details, so please, if anything you want to follow up, please do be in touch with me. I'm very, very happy to take comments, questions or contacts after this session. So next slide, please. So I'm going to talk about 3 things that we've tried over the years to try and bridge this gap between our academic knowledge and what happens in clinical practice. And the first thing I'm going to share with you is a method called critically appraised topic groups. Now, we found these really, really useful because they bring together the best of both clinical practice, the research knowledge, and also our librarians. And it really does facilitate a very rapid change in practice. It requires us to reflect on our practice, to highlight clinical dilemmas, and then to look for the very best research evidence that has already been produced to try and help answer those clinical dilemmas that we've had. So as I said, rapid change is possible, and it also supports ongoing learning, but I've also found that it fosters this relationship between academia and clinicians, and it helps for us to understand each other's worlds. It gives a sense of ownership, so that as clinicians we start to own our own practice and start to investigate what is happening in our practice. And it can also identify the gaps in the research evidence, so it can also then help support the research agenda going forwards. It also helps us start to identify other aspects such as research or audits, for example, in terms of being able to find evidence where it doesn't exist in the academic literature. But I've put a couple of things here that I want us to think about, really. If you're thinking about utilising this sort of approach, it does require consistent leadership. It does require people who are willing to lead the process going forwards, and that consistent leadership I've found has been really important, as well as making sure you've got good clinical representation, good support from sort of librarians and also your researchers. So those three key elements are really, really important in this method. So critically appraised topic is the first method I want to share with you. Next slide, please. The second method I want to highlight to you is what we call a community of practice, and I've used this in two major projects recently. One has been around translating the evidence from the NIHR's Moving Forward themed review, and a second project about trying to explore the links between mental health and neck and back pain. And communities of practice really mean that we bring together people who share an interest around the area that you're going to be working on. So, for example, for Moving Forwards, it was people who had a lived experience of musculoskeletal problems, clinicians, researchers, commissioners, academics. So this broad group of people come together. And what you get in this is a real understanding of your own context that you're trying to change. You will hear different perspectives. You will hear the problem that you're trying to solve viewed from with different lenses. So clinicians will have a particular view, commissioners may have a different view, but you all start to understand the context, barriers and enablers to that particular dilemma that you're trying to solve, whether that's embedding evidence into practice, whether it's about redesigning services. And really this community of practice gives you an opportunity to co-create meaningful solutions, because you've all got to be signed up to it. Patients, if it's run well, feel valued, and it can be a really powerful and liberating method to use. My kind of comments to you in terms of my reflections on this methodology, it's really useful. Evaluation is important, so keep an eye on how it's working and make sure you have an evaluation process alongside it. At times it can need sensitive leadership. If you're involving patients, then you might need to kind of create extra time or time before meetings to ensure patients are as well informed as they can be to participate. I found that project management has been hugely helpful in making sure that timelines are achieved, and both clinicians and patients may need your support to participate, as I've highlighted. Some resources are highlighted on this slide for you to follow up. So that's the second methodology, is community of practice. Can I have the next slide, please? So I'm going to title my third methodology for you as exploratory methods or people power. And we've recently taken a couple of steps into the unknown by employing two different types of roles. The gentleman you see on the left is Mr. Mike Brooks. He's our first patient to be embedded in our musculoskeletal service to make sure the patient voice is heard and recognised and acknowledged. And we also have employed Dr. Johnny Quick as an activity coordinator. Both of these posts are new, they're different for us in our organisation, but they're new ways of sharing the evidence. They bring about new conversations because they're very much community facing. So Mike is starting to have conversations with patients about what the evidence has meant to him in his experience of low back pain. And Johnny is starting to share the evidence about what social prescribing and engaging communities and different opportunities to stay active can mean. Mike has taken on the remit of, he calls it his ICE, so integration of services and opinions, communication and education is his reason for being, and he's with us for 6 months. So you think about communicating the message, whether that's research or knowledge, in a very different way. And we're starting to hear the question now from our patient groups as well, if you're not using the evidence, why aren't we using the evidence? So I think we're going to be challenged from a different group of people around what our services look like. And my challenge here would be for you to be brave, explore different opportunities, be persistent, and listen and support these new roles as they go forward. So my third method is exploratory methods, or people power. My next and final slide, please. So I'm going to stop now with just finishing this slide to say, just think about play to your strengths, work with the willing, and these are some of the key things that I've found have been useful given these 3 methods that I've shared with you. So working with the willing, create opportunities, seek out different opinions and voices, but also reflect on your own style, listen and lead, and collaborate with all that are involved. So I'm going to stop my 7 minutes and 10 seconds there and wish you all the very best for the webinar, and I'm very happy to take questions or follow up emails later after the session is finished. Many thanks.
Excellent, Kay. Thank you very much for your talk, and thank you for keeping so diligently to time as well. It makes my job a hell of a lot easier. Definitely wouldn't want to cut you off. There's been a couple of questions in the chat, and just take this opportunity to let everybody know that when you do put a question, or if you see a question in the Q&A, there's a thumbs up button, and if you click that thumbs up button, you can uprate the question. So if there's a very popular question or a question that captures what you're thinking, do use that button and bring it to the top of the list, and I'll be sure to ask the pertinent questions. And the first question, Kate, comes around involving patients within your work. Has there been anything you've had to consider regarding the involving of patients or people with lived experience with the work that you describe?
That's a great question. Thanks, Andrew. I think we very often, don't we, aspire to involve patients in our work, whether that's in service redesign, quality improvement, and we often want the playing field to be equal and level, but actually we know that's not true. You know, we're all paid to be at work thinking about how we improve quality, but patients very often come as volunteers or give their own time. And I was very keen with our role that we've just developed, which I showed you the picture of Mike. He's a peer support worker, so he's now going to be paid to be with us in our service, attending our meetings, asking questions from a patient perspective. And we're going to use this 6 months opportunity of him being paid 15 hours a week to try and get some data together on the impact of this role, for then taking the discussion to this needs to be a permanent role. How could we possibly live without this? So I think one of my reflections will be about how can you make sure patients are paid or given some remuneration for their time with you in your services. And one of my other reflections was thinking about, we did a project that involved people with lived experience of mental health, and I set this meeting up. It was busy. There was a lot to do in this meeting, and I really hadn't viewed that from what it must have felt like from a patient with lived experience of mental health to come into this environment. And they kindly fed back to me afterwards to say, look, you need to give a lot more thought about how your meetings are constructed, the support you might give to people, given that they might have mental health issues. And so that was a real lesson for me, thinking I can't run meetings as though I've got a group of very busy clinicians who can just tune into things very quickly. I'm going to have to give extra time and consideration to making sure that people are well prepared and prepared enough to contribute their opinions.
Brilliant, thank you, Kate. Along that line of thought, a second question that kind of comes to my head as you were talking there was particularly around kind of diversity and representation of the populations that we serve, and particularly the challenge that can sometimes pose when we're trying to include people with lived experience, but also represent the populations that we work with. Have you any thoughts about how we might involve people from maybe different backgrounds or different kind of harder to reach communities within this process?
really interesting, only because we've been having a conversation about that this week, Andrew. And Mike, in his role, he's kind of 3 weeks in, and already he's challenged me with this. I don't like that term, hard to reach. I really, as a patient, I don't like that. What he's turned that round is to we've not put enough effort in to reach those communities. So he's really flipped it round in terms of they're not hard to reach, we just haven't put enough effort in. And so I think Mike is going to help us think differently about how we might interact with our local communities, but trying to work hard, especially if we have a community of practice, we want to make sure that we've got representative views, but it might mean that we have to do things differently. So it might mean that we have to take the conversation to where the patients are. That might be in community groups, it might be community conversations, it might be groups meeting in sort of places of worship. I think perhaps we've just got to be a little bit more creative and think about how do we interact. How do we find where groups are, and then how do we interact in a meaningful way? So Mike's just made me think, gosh, it's about more effort on our part in terms of thinking about how we might do that.
That's a really nice way of looking at it, and as soon as you said it, it was almost a bit like a penny drop moment. And I think that's essentially what you're alluding to, is that it's so obvious when you think about it like that. We just don't think like that, do we, at times? Another question from the chat, Kay. Again, around the theme of patient representation, when patient representatives are paid and embedded within a research or clinical team, is there a risk that the authenticity of the patient voice can be lost?
Yeah, I think that's a fair point, and I think we will only learn from this. I mean, we're only 3 weeks into Mike's role. I've already reflected that the support that Mike needs it will be considerable, but I don't want to turn Mike into a sort of an NHS or a kind of a health. Someone who speaks our language. I've asked him to really challenge us from the patient perspective. So at every meeting to have well, what difference does this make to patients? So, you know, he's there holding us to account in a slightly different way. And I think if you have the right person with you, those conversations can happen. So already, you know, we've got Mike involved in our integration work, and he's already starting to say, well, how do patients know what's going on? Who's communicating this? How are you communicating it? So so I think it might relate to having the right person who has the confidence to challenge you. You know, I think that is an important thing to consider when you're going through the selection process, potentially.
Excellent, thanks, Kevin. I'm going to put a question which is a slightly different stance, move away from patient representation, but something that struck a chord with me whilst you were talking, which was around sensitive leadership and collaboration in particular. So we know that if we think around leadership within systems, and particularly within kind of the way the NHS long-term plan is taking us towards more systems leadership and collaboration, which I think we all can see the benefits and the value of. Are you able to expand upon how you see sensitive leadership to fit within that? And have there been any barriers that you've had to overcome as part of your community of practice work?
Yeah, I've put sensitive leadership, and I think I've kind of just invented that because I really, it was like you say, a penny dropping moment for me when this person with lived experience of mental health, I'm really grateful that they were able to say to me, you know, you didn't get this right. You really didn't get this right for me, given my difficulty being with people. And I just thought, gosh, you know, that does require a level of when we're sort of used to dealing with patients with musculoskeletal disease, and we perhaps step into areas that we're maybe not so familiar with, that we have to have either the voices that will give us that perspective, but also be very willing to hear that. You know, we all want to do the very best, don't we? And we all want to get it right, but very often we don't. But we have to learn from that. And I really was very grateful for that gentleman sharing that with me. So I took from that I really needed to make sure that participants, now whether that's patients, clinicians, commissioners, they have sufficient confidence to participate. So I think in sort of those barriers, it's maybe think about how we bring people together, but give them the skills or the confidence to be able to participate. And I see my role in perhaps creating an environment or creating a new structure where that is allowed. So we don't just have one meeting, you know, there may be preparatory sessions where people can join to share an understanding of the context, to even be in the conversation about the context. So I think sometimes, you know, we're all so busy that we sort of rock up to our meeting thinking everybody's happy, you know, they understand all the issues, but maybe there's some preparatory work, both, you know, for all participants to allow that to happen in a meaningful way, really.
Excellent. Thanks, Kay. You've got to know that the grilling and the Q&A is over, and I'm mindful you've still got a few moments with us, so you might be back towards the end for the panel Q&A if you can. But thank you so much for the time you've taken today, and also your thought-provoking talk. It really was excellent. So thank you for that.
Thanks, Andrew. Thanks, everyone.
Pleasure, Kay. So our next speaker is Professor Chris Littlewood. Chris is a Professor of Musculoskeletal Research at Manchester Metropolitan University. Chris is also my lead PhD supervisor, so it's going to be a little bit strange to be the one asking the probing questions for once, but an opportunity I will no doubt enjoy. And Chris's talk is titled "Research Brings Opportunity, Not Threat, so let's embrace it." Over to you, Chris.
Thank you, Andrew. Excellent talk here. Really enjoyed that. So I guess any process of meaningful change begins with recognition of a meaningful problem. And over this next few minutes, I want to reflect on how important research is for that purpose. So next slide, please. So looking back and some background and context to this talk, when I trained in the 90s, we spent hours perfecting what we called grade 1 mobilizations. So for those who aren't familiar with that, that meant we spent hours very gently pressing on someone's skin, expecting that would move a spinal joint 4 or 5 inches away under layers of fat, muscle and other tissue. It was absurd even at the time. We also spent hours perfecting what we called deep transverse friction massage. So again, what that meant is that we spent a long time rubbing people's skin until our fingers couldn't take it anymore, theoretically breaking down adhesions within tendons. And as I said, at the time, even as a student, we questioned that, but that was the context that we grew up in, or at least I grew up in. But clearly there was a problem. So it was then interesting to observe the subsequent change. So next slide, please. So during this next few minutes, and perhaps through the rest of the webinar actually, I want you to reflect on this question. So once you're fed and watered, once you're secure, you've got a roof over your head, what makes you get up for work in the morning? So that's what I want you to keep thinking about as I'm talking. Next slide, please. So the start of the story for me today is the publication of a randomized controlled trial 10 years ago, where Kim Burnell and colleagues in Australia, they took people with what they called rotator cuff disorder. So those are people with shoulder pain. They can still move their arm, but it hurts them to move their arm. It's a pretty common problem. And they took a package of exercise and manual therapy supported by a physiotherapist, and they compared that to sham ultrasound, so a machine that many physiotherapists used to use in the past. But essentially, we've got a comparison of what was regarded as a good program of physiotherapy versus a sham treatment 10 years ago. Next slide, please. And the results were surprising. So in terms of the measure of both shoulder pain and disability from the patient's perspective, after the treatment, so 11 weeks after beginning, there was no difference between a program of exercise and manual therapy and sham ultrasound. 6 months down the line, again, there was a small difference, but that wasn't clinically important to either the clinician or the patient. But what we see now, we look at guidelines, recommendations, exercise infiltrates these guidelines, and I see absolutely no reference to sham ultrasound, despite comparable clinical outcomes. Next slide, please. More recently, reflecting on a trial that Kay was central to For the purpose of this talk, the group were comparing a program of structured, progressive, physiotherapist-led exercise. Again, what many would recognize as contemporary treatment. So this was a one-to-one program, a range of progressive exercises compared with an exercise leaflet. Okay, next slide, please. So 6 weeks after beginning in this study, there was no difference between this program of individualized physiotherapy, contemporary best practice treatment, compared to a single solitary exercise leaflet. Now, 6 months further down the line, there was a signal of benefit for the physiotherapy program, but it was of marginal clinical importance. And by 12 months, that difference between this reasonably intensive physiotherapy intervention and the piece of paper was no longer apparent. Next slide, please. We're about to see the publication of the largest randomized controlled trial in this area, where over 700 people were recruited. So in this trial, again, it was an individualized program, including a number of visits to the physiotherapist versus one session of physiotherapy. And I won't spoil the results, we can wait for the publication, but I expect that many of you on the webinar will be able to predict the outcomes of this trial with a reasonable degree of certainty. So next slide, please. So we had the problem of grade 1 mobilizations, friction massage, etc. in the 90s, and then we saw exercise as this silver bullet, that the answer to these common musculoskeletal problems. But if that was the case, why are the outcomes from these trials just so unremarkable? Next slide, please. So returning to my question, what makes you get up for work in a morning in this context? Next slide, please. Well, from a physiotherapist's perspective, in my view, if the patient and the NHS are the reason that you get up in the morning, if that's what's driving you rather than financial gain, ego, etc., then what this research helps us to do is recognise that we're only scratching the surface in this area, and we can choose to keep our head in the sand, or we can really think about how these research findings might stimulate us to think, practice differently, improve what we offer. You know, I'm sat here today reflecting on my past self 20, 25 years ago, all that time pushing, rubbing, not being very happy. But I wonder in today's context, how might the future you reflect on the way you think and practice? So 20 years from now, what will you think about what you currently do? Next slide, please. And final slide. So just a cartoon to leave you with. If we do take this stimulus from research seriously, and we do think about new ways, almost what I'd call a thinking rather than a following paradigm, then perhaps this applies. No, sweetie, embracing a new paradigm doesn't mean daddy's been hugging someone other than your mother. So just because we are a physiotherapist or we are a surgeon or whoever you identify as, just because the research challenges our current thinking, if our focus is the patient and the NHS, this can be a really useful stimulus to make things better. Thank you.
Thank you, Professor. Really, really nice talk as usual. I probably a couple of questions. I see there's a few coming through on the chat, but whilst they're coming through, I'll pick a couple of my own when I've got an opportunity to probe. And I think what's really interesting here is calling out the elephant in the room. So as physiotherapists in particular, when we think about a lot of trials that have shown difference between surgery and physiotherapy, and we often see that physiotherapy, well, there's no difference in clinical effectiveness, but usually more cost effective. And we champion that, and we bash surgery in the same breath. But the data that you've presented there obviously does provide challenge to us as physiotherapists in terms of what we think is the good outcome, is a good intervention, is often no better than, as you say, a sheet of exercise. So what do you think are the take-home points then for physiotherapists, particularly clinicians that are watching this today, who might be watching this webinar when they've got a couple of patients afterwards in their afternoon clinic? What are the immediate take-homes for you in terms of the messages for the clinician?
The immediate take home is let's not see this research as a threat. There are enough patients out there many who need our support, and for example in the COVID context. So where we're seeing that these intensive interventions aren't more effective than minimal or brief interventions, for example, let's embrace that. Let's use our resources more efficiently. But I think for the individual clinician, what I'd really like to see, this is why I'm a real advocate of CARE's critical appraised topics and the communities of practice. I'd really like to see those models become commonplace across our NHS, where individual physios, groups of physios, really, they're using their own thinking to develop ideas, to develop practice. Whereas at the moment, I think within our profession, we still risk being kind of guru or expert led. And my question really is, where have those gurus and experts led us to? Is this where we wanted to be? So I'd really like to see that more, frontline clinician up driven approach to, research and quality improvement. And CARE's model is a great example of how to do that really well.
Thanks, Chris. And what would your thoughts be in terms of how we define better, or how we define that somebody has improved? So by looking at a lot of the trials that kind of pain or function as an indicator of better, there is obviously a school of thought, particularly from an exercise perspective, that you get secondary health benefits from engaging in activity and an exercise program that you might not necessarily get from simple advice or brief intervention. What are your thoughts on that? So the secondary benefits that may not necessarily be measured.
Yeah, I mean, I think just to answer the first part of the question, one thing that perhaps we don't do well is that we don't understand what's important from the patient's perspective. That's now why in any research that we do, we partner and we work with patients, not as participants in the research, but they work with us. So that's the important thing, both for researchers and for clinical services. What's actually important to your patients? Now, the second part about the secondary benefits of exercise, it's a non-starter of an argument in the context of physiotherapy, because, for example, we don't prescribe couch to 5K for people with shoulder pain. We might give them an elastic band or tell them to do some dumbbell exercises or some push-ups. And in the kind of exercise that many physiotherapists currently prescribe, you don't get those secondary benefits. So really, it's not an argument that holds up for me until people start prescribing parkrun for shoulder problems. And that would interest me.
To be honest with you, I think that would be a really interesting trial. I think we could both hazard a guess in terms of what the outcomes may be compared to a best practice intervention. Let's take a couple of questions from the chat. There's a little bit around methodology, and to what extent do you think randomised controlled trials are able to tell us or provide insight into clinical practice, and are there actually better methodologies that relate or translate better to clinical coalface?
Yeah, I mean, it's a point that's put to me quite a lot, and with respect, often the points that are put to me are often outdated critiques of randomised controlled trials, not recognising how trial methods and approaches have evolved over 20-25 years, and the trials that many of us work on now are pragmatic. They're embedded within usual clinical services, so I think are probably more reflective than what some outspoken voices try to suggest. So is there a better method? I mean, it always depends upon your research question, but if you're looking to determine whether a treatment is effective, then at the moment we have no better way than randomizing people to different interventions. Otherwise, the risk of bias really scuppers any potential results. But I've got to declare a conflict of interest as a trialist.
Thanks, Chris. And if we step back from our physiotherapy worldview, I think we're all seeing the benefits of a randomised trial at the moment. We see the rapid development and implementation of the vaccine. So thank you for all that. So I'm going to move on to our next speaker now, guys. But do keep the questions coming in the chat, and as we get to the Q&A at the end, they'll be very much utilised to populate the discussion. So our next speaker is Andrea Gibbons, and having discussed academia and the translation of knowledge into practice, Andrea is an expert in this field. Andrea is the founder of Evidence for QI and is an improvement evidence lead. And Andrea will be talking to us on the use of evidence to inform quality improvement. Over to you, Andrea.
Thank you so much, Andrew. as Andrew's just introduced me, in this session, I'm hoping to convince you that you're missing a trick if you don't use evidence for quality improvements. However, having listened to the last couple of fantastic presenters, I'm very conscious that I'm probably preaching to the converted here. Sadly, in my experience, quality improvement teams do not routinely find and use evidence in their quality improvement projects. So we've talked about sort of clinical focused work, but actually in kind of some of the service improvement type activity that we do, it's not the default position that we necessarily routinely look at what is going on elsewhere, what other trusts are doing, etc. So that's what I'm hoping to talk about today. And given the fact that there's an audience here of champions who are totally sold on this, I would encourage and urge you to take that message out to those colleagues, which absolutely do exist in quality improvement teams across the country, to encourage them to use evidence. So as Andrew said, I am the Improvement Evidence Lead at Somerset NHSFT, was previously an improvement advisor, and I'm leading a national project at the moment with some of the people on the call, which is funded by the Health Foundation and NHS England and Improvement. Next slide, please. So this is just a little bit about the project, and the problem and aim here have been co-created with members of the quality improvement community and with the library services and knowledge specialist community. I should point out that the project that we're working on was voted for by the 4,000 plus members of the Q community, which is a quality improvement community run by the Health Foundation. So this is a problem that people absolutely can relate to and appreciate in their own working practices. The project, as you can see, was set up to tackle the problem on the left-hand side around the fact that quality improvement teams don't routinely use and find evidence in their projects. When they look for it, they get overwhelmed with too much information of various types and quality, and struggle to find what they need in a format that they can use. As a result, we repeat mistakes, work less efficiently, make uninformed decisions, and reinvent the wheel. So what the project that we're working on is trying to do is connect QI teams with evidence in 3 ways. We're trying to partner with libraries to support the needs of QI teams. We're building networks and breaking down organisational and geographic silos. And finally, we're trying to enthuse people who don't naturally think about using evidence to use evidence and think about how they can embed it in their day-to-day practices. It's not rocket science, but it is notoriously hard, and there are lots of reasons why we find it difficult to use, share and apply evidence in quality improvement. Could we have the next slide, please? So in QI, and I certainly speak for myself and the teams I work with, we often feel alone, as though we're the only ones who are tackling a specific problem. But the good news is that we're not alone, and few QI projects are really unique. The great thing about this is that it means that others elsewhere are almost certainly working on the same problem. And if we can find them and find out what they're doing, then we can build on it and use their learning to inform our decisions. Next slide, please. So what is it that's stopping us from using evidence in quality improvement projects? I'd love to hear why you think that might be, but in our project we find that teams commonly tell us the following: that there's not enough time, finding evidence takes too long, that there's too much evidence out there and that it can be overwhelming and make them feel overloaded, that they don't know how or why or where to find evidence that might help them, that they don't think there is any evidence that will help them because their situation is so unique, that they don't like libraries, they're not readers, and academic articles aren't for them, that they've tried it in the past and it didn't help. And you might notice that some of these barriers resemble barriers to why frontline teams don't always engage in quality improvement projects. Could you go to the next slide, please? So in order to understand why evidence can be so valuable, it's really important to think about what we mean by evidence in quality improvement. What counts as evidence? So I'm suggesting to you that evidence in quality improvement is slightly different to traditional academic evidence. If we think about traditional academic evidence of the type that we've been talking about so far in this webinar, this is a type of evidence that clinicians or academics will be most familiar with. When we think about traditional evidence, we often think about journal articles, books, posters, or conference presentations. Typically, traditional evidence has the following characteristics. It has an academic writing style and is often scientific. It's comprehensive and follows a set structure, including sections such as a methodology and limitations. It's peer-reviewed. There are long delays between submission and publication, and there are often charges to publish and access that evidence. In contrast, in quality improvement, our needs are slightly different. We need to be nimble, responsive, and proactive. So I'm suggesting to you that evidence in the context of quality improvement has the widest possible scope and comprises any information that can help our quality improvement projects. It's a little bit like the use of evidence in legal settings. A much wider range of knowledge can count so long as it's valid and relevant and you can learn from it. So for evidence for quality improvement, it's not just quantitative, scientific or academic evidence. It may include, for example, presentations, videos, articles, lessons learned, videos, reports, policies, tools and blogs. Really good evidence for quality improvement will be recent, relevant and help shape thinking about quality improvement projects. Ideally, it will lead to the project being able to reuse and build on the work that others have already done, rather than starting with a blank sheet of paper or reinventing the wheel. It will help inform decision making, helping us better understand the problem, identify change ideas and select the approach most likely to work. It will help us save money and time and get to a solution quicker. It will help develop and build business cases and learn from others that have already done something similar, and it will help us find new ideas and innovate. Can I have the next and final slide, please? So what can you and your colleagues who may not be converts to using evidence for quality improvement do? And I argue that it all comes down to one word, ask. So I'd like to challenge you and them to ask 3 times. First and foremost, ask your library service to help you and your teams. They can help with horizon scanning, literature searches, help with writing up and sharing our work, and much, much more. They can do the heavy lifting of finding and filtering QI evidence for you. Secondly, ask yourself, are you using, documenting, sharing and applying QI evidence in your work? Do you know what others working in a similar space are doing? And do you know who else is working on similar projects? What information might give your project a better chance of success? And what might you be able to learn from others that would help you? And finally, ask others, what's the evidence for their decisions? Who have they spoken to? And who else has done something similar? Thank you very much for your time. If you'd like to learn more, please do feel free to reach out to me on Twitter or by email at andrea.gibbons@somersetft.nhs.uk. And please, please, please do engage with your library service. Thank you.
Excellent, thank you, Andrea. When you were talking now, I was hearing the parallels to all of the barriers that I hear from clinicians who are engaging with evidence-based practice, evidence-based medicine. And one of the things I was reflecting on as we were talking was this concept of repeating work or duplication, and particularly reflecting on some of the things that we've noticed within Connect recently, where rather, if there's a problem that's known out there, there's literature, there's evidence out there. What we were seeing with the teams that were engaging with their QI projects would then survey staff, or they'd send out an MS Forms or a Survey Monkey, or try and do a focus group internally to try and understand that problem. And what our advice at the time was, well, if that knowledge already exists in some form, then why replicate it? because one of the I think one of the kind of implicit impacts that potentially has is that the culture of QI isn't moved forward. If you're boring people, if you're making them to do things, if you're giving them, particularly in a virtual world, lots of other virtual things to engage with that might lead to virtual fatigue, then it kind of goes against that cultural piece we're trying to change in terms of embedding QI principles, embedding QI thinking, within everybody working within healthcare. Do you have any tips there for us? I know you mentioned at the end there those last 3 asks. Any kind of real practical tips for QI individuals or people taking QI projects about how they might be able to start using evidence within their project tacitly?
Absolutely. So thank you for that question. I've emphasised the need to engage with library teams. I would absolutely encourage everybody to make that contact. And if you're not getting exactly what you need, then have that dialogue. There is so much experience and skill on the ground that can take the heavy lifting out of looking and using evidence for quality improvement for you. So first and foremost, engage with your library team. Hopefully many of you will be aware of the Q community, which is a network of quality improvement professionals across the country. Anyone can join, and this is a fantastic opportunity really to engage with the quality improvement community and connect with people tackling similar challenges and problems. And it obviously builds on the conversation we had earlier around communities of practice. You don't actually need to be a member to engage in some of the special interest groups, so that's something that's certainly available to anybody listening. As a team in Somerset and on the project, we produce a number of materials that anyone is welcome to use. So there is a monthly evidence update that we share that you can find by going to tinyurl.com/QI monthly. It's also on the Academy of Fabulous Stuff site. That is a monthly update of quality improvement evidence that's been released in the last month. And it is always freely accessible. So anything there that you find will be free and easily accessible to you. And finally, we do run some evidence for quality improvement Pinterest boards where we link interesting resources. So those are available on Pinterest. But first and foremost, join the Q community, speak to your librarian. Those two things are absolutely fantastic and very accessible to anybody listening.
Excellent, thank you, Andrew. I've got a couple of other questions for you, but I'll save them until the end. So I'm going to move on to our next speaker, who is Luke Bomba, who I'm really excited to hear from this afternoon, as Luke is an Associate Director of Quality Improvement at Nottinghamshire Healthcare NHS Foundation Trust. And Luke will be discussing how utilising both data and KPIs to change and enhance behaviour, improve performance within Nottinghamshire. So over to you, Luke.
Thanks, Andrew. Hi, everyone. Thank you for inviting me here. I really enjoyed that, Andrea. Thank you for that that conversation and that presentation. I found that really interesting. I think absolutely chimes with what I'm going to talk about in terms of the use and progress of quality improvement. This is a nice return for me because I'm actually redeployed at the moment into setting up and managing the Nottinghamshire Integrated Care System Vaccination Operations Centre. So that sounds really current and important, doesn't it? But actually, it's complete mayhem. So I'm fully in the vaccination programme at the moment. So this is a nice return to quality improvement for me. So let's dive straight in. Next slide, please. Thank you. So I'm going to keep it very sort of straightforward and simple today. The title that Andrew has just read out involves a whole range of different elements of quality improvement that I can't possibly attempt to cover. But very quickly, just so that we know what it is that we're talking about. Quality improvement is not necessarily just a literal, improving stuff. It's not just about improving quality. Some really important principles that I just wanted to share with you. Certainly how we approach this in Nottinghamshire. It's staff-led. That means it's you. It's not quality improvement specialists or experts necessarily. They can help, they can support, but it's all about you, those closest to the care, clinical experts, you guys. So when we say quality improvement is staff-led, it's very much that cultural piece that Andrew mentioned a second ago, cultural embedding quality improvement across a whole workforce, really important. Obviously patient-centered, but not as in, you know, tokenistically tick a box, get a patient involved. We're really looking at good quality co-production, co-design, all of that real good stuff so that we can design quality improvements together. And I think it's some of that design that Andrea was just talking about. Where do we go when we're designing new stuff? What do we go to? Do we just think creatively and apply innovation? And of course, that's absolutely central. But there's a whole wealth of information and evidence to draw upon as well to bring that design together. So focus on measurement. Otherwise, how do we know that it's improving? That's a really sort of basic but fundamental question. If we're doing quality improvement without a focus on measurement, then we're just going on whether it feels better, whether it looks better, what does better mean? So we need to be a little bit more scientific. So we're really looking to use measurement, and then a consistent methodology. And over on the right there, you can see the model for improvement. I know many of you will have seen this before and be familiar with it, but there may be some who aren't. Just those 3 simple questions at the beginning underpin our whole approach to quality improvement. So crucially, what are we trying to accomplish? Of course, we've got to start with an aim, otherwise we can go in all sorts of different directions. And I've seen loads of quality improvement projects lose focus just because it's not really clear what it is you're trying to do and where you want to go. And this one in the middle is really important. It relates to measurement that I was just talking about. How will we know that a change is an improvement? How will we know that the change is an improvement? Otherwise, it's just a change, isn't it? We've got to define the improvement, and we've got to be really clear about what we're measuring. And then this third question is the creative bit. What change can we make that will result in an improvement? What possible changes could we make? And this is the link to design and link to evidence that Andrea was talking about, as well as the creativity and the innovation. So at the bottom there, just a few kind of project management sort of steps that are involved in understanding what your quality improvement needs to be about, identifying the quality issue, really deep diving into the problem, a whole range of change ideas and evidence and creativity to result in a testing program where we're really testing and looking at the measurement and evidence of what's going on with our intervention to move towards implementing and sustaining. Next slide, please. Thank you. So how do we change behaviour? That was an element in the question. You'll all have your own idea about this, but actually, if you think about behaviour more generally, how do we change behaviour? How do we change the behaviour of others? Is it by showing them lots of graphs and data and forecasts? Is it about incentives? Is it about punishments? Is it about KPIs? Those are all important. I think they all have their place. And I think people are all different and respond to different sorts of motivation and stimulus. But in quality improvement, I've absolutely found that it's all about engaging people in a common objective. If it's a case of service change or transformation across clinical services, for example, and people aren't engaged with that, they don't know what it is, they don't know what's coming, it's just improvement that's done too, isn't it? So you've got to agree together on what you're trying to achieve, and that is so fundamentally important. It sounds very basic, doesn't it? But actually so many improvement projects go sideways because this agreement, this engagement, this participation hasn't really happened right at the beginning. So it's fundamentally important about changing behaviour. Thank you. Next slide, please. So I just wanted to touch briefly on a little bit of chart action. This is a basic run chart. It doesn't really matter what it's about. I'm just going to show you very simply the difference and the change that you can see in that data. So in quality improvement, we really do like run charts. Data over time is absolutely critical, as opposed to dashboards and red, amber, green stuff that don't really tell you exactly what's going on. So this is a run chart. You'll see patients along the bottom. So you'll see that when we get to patient 21, something has happened and something is very different here. So the data has done something very different, and that is a clear shift. And the point that I'm raising this with you is because how do you know that you're making a difference? If you're tracking the data over time, you will see, or hope to see, the shift that is directly attributable to your intervention. So there might be a plan, do, study, act cycle that was on my first slide. It may be anything that you've tried that's done differently, but if you're tracking and measuring the right stuff, then you will see this direct change in the data, or you will hope to. Perhaps if you don't see it, that's significant as well. So just trying to keep it very straightforward. In managing your quality improvement, you know that you're making a difference when you see that intervention, and then it's a question of attributability, isn't it? is the change that you're seeing in the data directly attributable to the intervention that you have made? And that's why it's so important when you're approaching quality improvement that you change things one at a time. You're really clear about, we changed this and we saw this difference. Yeah, you'll see some very sort of clear clinical and medical correlations in that approach. Next slide, thank you. Okay, so we do lots and lots of quality improvement projects. Some of them are large, trust-wide, or sometimes system-wide improvement work. You'll see the little posters around the edge of this slide that highlight some of that, some charts and pictures and all the rest of it. I know you can't read it, but that's just for sort of context. 3 really important points I just wanted to raise with you here. So the importance of individual patient stories. You know, how do we change behaviour? How do we use KPIs? How do we use data? Well, actually, how do we use the real important patient stories? So we can have an individual impact here on patient stories, on the impact of the improvement. So it is really important to delve straight into the real detail of singular and perhaps even group patient stories that show the power of the intervention and the improvement that you have made, and hopefully that you have made with them. At a team level, you know, QI is all about you, it's all about being staff-led. We see real significant differences at a team level with the impact of undertaking quality improvement work on the morale of teams, on attendance at work of teams, and on communication and teamwork generally. So coming together to work together to agree this common objective to try and test and create brings a real sense of team and community. And then thirdly, from a service level, in creating quality improvement and embedding quality improvement so that patients and staff can work together to drive their own co-produced improvements. That question that was raised earlier about why do we come to work in the morning, for me it's definitely about this, making a difference for patients with them, working together to achieve those differences and those improvements. Next slide, please. Okay, my final slide is just to show to you the Nottinghamshire Integrated Care System Quality Improvement Training Approach. It's called QSA. Many of you will have heard of it. Just look at these modules in this training programme. So we run this regionally as a QI collaborative. So you'll see there the modules in this programme about demand and capacity. You'll see modules around leading improvement, project management, measurement for improvement, sustaining improvement, creativity in improvement, a whole range of really thorough module learning to increase the capability and confidence of the workforce in the local system. So I'd encourage you to search that out and by all means contact me if you're interested in finding out more about this programme that we offer. So I'll pause there. Thank you for listening.
Excellent talk, Lou. Thank you very much for sharing your experience with us. One quick follow-up question, just mindful of time, and guys, just again to prompt to put your questions in the Q&A, and after the end of the webinar, if we don't get a chance to answer the question, we will be sharing a document afterwards. But by way of quick question, Lou, in your opinion, are there any prevalent themes that of QI that healthcare providers are continuously challenged by? You've outlined really nicely different modules that you do as part of Nottingham training. What are the ones that are kind of most commonly a challenge to healthcare providers?
Yeah, there's a few that spring to mind, Andrew. I think the first one is in terms of a theme of improvement, flow. It's absolutely crucial at the moment. We need to vaccinate hundreds of thousands, millions of people. So getting the right flow of patients through the door, working with them in a way that maintains quality. So flow is crucial. It's crucial in A&E, but it's crucial in many services, isn't it? How many patients do we need to see through the door, and what does that really look like? So that's a real challenge. It's a real challenge because of the quality risk sort of ratio. So actually, if we push a lot of patients through the system, through the clinics, are we still happy with the level of quality that we're providing? So in terms of designing improvement, that sort of flow versus quality is always a real key issue to try and level up. The faster we flow people through, we think that we're going to lose quality all the time, and often we do. So I think flow is crucial. Then there are real themes, obviously, about safety as a theme. QI projects that are really looking to increase safety and reduce the risk particularly clinical risks in certain settings as well. The other one I'll just mention is about variation. So throughout quality improvement, variation is this real important theme, and where we have unwarranted variation, so where we have lots of services across a particular geography, but actually if you're a patient who lives in this postcode or lives in that postcode, you get a very different service, and it's commissioned by the same people, it's provided by the same provider, for example. So why is it that there is such a variation? And a huge amount of improvement work is about identifying where that variation is, why it's there, reducing that variation, so we get a really nice, clear, standardized flow where we're really happy with the quality components of the care that we're giving. So a few spring to mind there: flow, quality, safety, and efforts towards improving variation for consistency of patient access, care and experience.
Excellent, thank you, Luke. I think we really nicely alluded to there is how quality, particularly when I think about this from a clinician perspective, we can sometimes think quality is synonymous with effective, but there's so many different other factors that underpin quality that we need to consider. Excellent, thank you very much. And finally, last but not least, it's a pleasure to welcome Rob Tyler. So Rob is the clinical lead for our MSK and pain service in Northumberland, as well as the research lead for Connect Health. And Rob will be talking about the innovative and evolving journey with clinical support tools that Connect have been on to aid knowledge translation. Over to you, Rob.
Thanks very much. Yep, just getting some of my notes out as prompts, because I was furiously scribbling based on the last presentations and seeing how can I apply this in the environment that I'm working in at the moment. So thank you very much for all of the speakers that have led up to this, and hopefully mine will give you an overview of what we're trying to achieve within Connect and sort of the process that we've gone through over a time period to make our what were previously known as clinical guidelines, but not known as that now, a little bit more user friendly and applicable across the board. Next slide, please. So I'm presenting a lot of content and credit has to go to Dan Bork, who put together a really good means of coaching and supporting the individuals involved in the 10 and 10 guidelines, and he did a fantastic job of facilitating, feeding back, providing sort of prompts to amend certain language choices and support on those who weren't too sort of sure how to proceed with some of the recommendations that were being made. So unfortunately he can't make it today, so I'm presenting on his behalf. And what we did is we had these 10 and 10 what were called guidelines at the time. We put a survey out to the staff to sort of figure out, were they being utilised in the way that we thought they should be utilised? How valuable were they to the staff that were using them? And these are some of the phrases that were coming back. We also took feedback from external bodies as well, so people who maybe reached out to us via social media or just in conversation and passing when we've been to certain conferences and met people who we know on those conference circuits. And we therefore decided to revisit those guidelines as they were called at that time. Next slide, please. And the process that we took is Andrew Cuff and I and Phil Barber got our heads together, had a little look into what were these documents really trying to achieve, take on board some of the feedback that were given from the staff, from the external bodies, and try and collect all of these sort of key areas to make them a little bit more user friendly. So some of the things we sort of identified is that they hadn't been reviewed in quite a while, a couple of years, and they didn't really satisfy the definition of the term guideline. That was some of the big pushback that we received and that we reflected on. The methodology that was used in the production of the original ones was a little bit varied. So going back to the previous point of unwarranted variation, even within the same organisation, and that's because we had a number of clinicians who were providing their time and effort across different conditions with their thoughts on how to best identify the research and appraise the literature. There wasn't a great deal of clarity regarding how people arrived at their RAG scores, and so that lack of consistency meant that certain thresholds might be met for one condition but not for another, yet that was the same intervention and a very similar condition. So again, unwarranted variation with that. And to be fair, the intentions were set out to be positive, and we've learned from those mistakes, and we've used that as a springboard to move forward and develop something hopefully a little bit more user friendly. And we've decided that we will call them clinical support tools as opposed to the term guideline. We also wanted to include other areas that were evolving within physiotherapy, so things like the FCP movement that's been made in the last few years weren't included in our last guidelines because it hadn't really existed in the way it currently exists, and so we included that as a primary care level guide on what to do on for those people who turn up with the acute presentations. And then we tried to tidy up the presentation style, so made sure that the citations were used in a similar format, made sure that the things that make a big difference to the readability of it, so that the font size, the sort of the way the layout of the document was put together, and we put together a few sort of transcending themes and principles across those guidelines. Next slide, please. Those transcending themes and throughout the clinical support tools weren't something that was largely based on strong RCT evidence, but it's what we've come to know in healthcare as really important factors within dealing with people who present with conditions, and these are things along the lines of shared decision making, person-centered, goal-focused approach, recognizing the effect of psychosocial contributory factors to even acute pain, not just persistent pain, making every contact count, so making sure that we identify these factors from a social aspect which are important to their current presentation: smoking, alcohol, social care needs, access to talking therapies, social prescribing, as well as some services are sort of branching out to now. We're getting a lot more people who are accessing things like community support groups and art therapy, certainly within our region that we work in. But also going back to sort of fundamental principles of exercise and progressive load, and making sure that there's an understanding of how we apply those, even in the absence of a great deal of strong evidence of strength training as such. The example I can bring is the osteoarthritis ones that I covered. There wasn't really a great deal of the research that actually adhered to the clear principles of strength training, yet we know that there are some benefits of becoming active. The thing that was also quite different was we put together sort of an introductory statement across those clinical support tools to recognise that there is uncertainty. We can't say that you must do this and do that, create a formula to help people get better. There has to be some nuance within that clinical contact, and it's no longer, or hopefully doesn't appear, that we're saying to people, you should not do this, do not do that. But there has to be a good reason to do that in the absence of evidence. Next slide, please. And this would be how an example of one would look. I think this one was for an Achilles problem. And on the right-hand side, you can see a list of all the ones that we've covered, all the conditions that we've covered. And we've red, amber, green scored it based on a little bit more clarity of what constitutes a red, an amber, and a green. And so the green would be clear evidence of effectiveness in the literature with minimal known risks. Amber would be less certainty within the evidence with, again, uncertainty around the level of risk. And so heavily, a shared decision-making process is heavily needed in order to make sure someone's choosing appropriately those that are on those amber lists. And the red score would be, an absence of evidence or clear known risk, where we really would discourage people from using those interventions unless there is absolutely no alternative. Next slide, please. The documents were quite large, and so what Dan put together was this sort of infographic. And again, it's a bit too much to digest on this presentation, but it's not for you to sort of pore over right now. It's just an example of how a clinician can take this, look at it, see how this represents the guideline or the clinical support tools, as we're now calling them, sorry, and can put those interventions into place and into practice. You're not going to take a snapshot of this and know exactly how to treat every single person. It just gives you an idea of, well, if this doesn't work, what do we do next? What is available? What's not necessarily the best treatment, but the next best treatment because they can't access that best treatment due to health conditions. Next slide, please. So once we put all those together, those have been reviewed by a few of the senior leadership team and the medical directors, and the idea being is that we've given this sort of seal of approval of this is the direction of travel we want to head with these documents. They're not do's and don'ts. You cannot and will not do this. They're more guidelines of from a supporting clinicians to use best evidence within evidence-informed practice. And I think that's what we need to be clear about here, is that they are not, you cannot do, you will not do, you should not do. They're have a good think about it. This is what the evidence currently says. We know this evolves, we know this change, and in its current guise, we're quite happy for you to use these to help inform your decisions. Next and final slide, please. And the next step would be for those 1980s babies is to roll these out as per Optimus Prime. Make sure that we get these into the laps of every clinician working within our organisation, support them on how to interpret them, which we have done through video lectures. We've run a series on how they were constructed and how we'd expect someone to use them. But by all means, these are due for review and revision as we go along. They're not the final entity, and they'll never be finished.
Excellent. Thanks, Rob, for your great talk there. And just to let everybody on the webinar to be aware, the tools that Rob alluded to are fully available on our website. If you go onto the Connect Health website and onto the clinical expertise page, you can access those tools. So we'll get going with the Q&A. And the first question is for Luke, and it's something that was, I think, probed from when you mentioned that you've been redeployed onto the vaccine effort, with your background in QI. It'd be really interesting to understand how QI principles have been utilised within the rollout of vaccine delivery, and in particular, what that iterative, that quick testing process and some of the improvements you might be seeing local to Nottingham. I'm not expecting you to talk on behalf of the government more broadly.
Yeah, this is a really good question, and I think just very briefly. So, of course, we're in a command and control situation as we are across the world. So, in some ways, you might think, well, that's not really in keeping with quality improvement. You know, these sort of national directive stuff coming out centrally from central government every single day. So in some senses, it's not necessarily about quality improvement per se, but I do understand where this question comes from. There is something that's very rapid, obviously, about this vaccination programme, and that is akin to core QI principles. You can do quality improvement very rapidly because it is about iterative changes. It's about very rapid learning, and that has been a cornerstone of this programme so far. So something about the speed, the tempo of all the changes, the rapid testing. I don't mean testing for COVID, I mean testing of interventions and testing of solutions, testing of how this is going to work. So we've got services all across the Nottinghamshire system who are setting up, then doing it differently the next day, learning, doing it differently the next day, making improvements each and every day. So that for me is the fundamental essence of what quality improvement is all about. And that is happening on a huge scale, probably across the world in terms of the vaccination rollout. And that is really about adapting as well. So it's something there about learning, and it's about adapting and making those changes as rapidly as we possibly can to maximise all sorts of different components of this programme, whether it's about flow through, whether it's about safety, whether it's about quality, and some of those elements I mentioned earlier. I hope that helps. Excellent. Yeah, absolutely. And I think on that line of thinking about adapting and kind of broadening kind of the vaccine rollout, one of the questions in the chat, which when it comes to Chris to take first punt at, and I think it stems from Andrea's talk about widening the use of what we consider to be valid evidence to inform QI beyond obviously the academic literature. I'm just interested, Chris, what would your advice be for determining the quality of the evidence to appropriately direct decision making if we are broadening what we consider to be valid evidence to inform translation of knowledge?
I'd probably just push back on the question and the concept of valid evidence. You know, I wouldn't be a strong advocate of using blogs, for example, or other pieces of information as valid evidence. There might be useful information that you consider, but you know, if we're really serious about doing things as well as we can, then we think about the questions we have and then we match the methods to that. And you know, if we are serious about offering the best quality interventions, both clinically and cost-effective interventions, then we need to invest in large, high-quality randomized trials. My concern is there's an element of seduction around other sources of information, but that seduction, as we reflect on our past, has often led us to, for want of a better term, the wrong answer. So I think we need to do things bigger, better, and really focus on what is valid or otherwise. And of course, that doesn't always mean the randomized controlled trial, but yeah, I'd be cautious.
Thanks, Chris. And Andrew, I don't know if you want to come in on that point, because there's a little bit of that tension then, isn't it, between what we consider academia and obviously the clinical quality improvement, translation of that knowledge.
I would dearly love it if we could have robust RCT level quality data for the quality improvement challenges that we're all facing. There's a massive vacuum and a disparity between what, I mean, you guys know so much better than I do, but research is not directed consistently by what services need right now, and the timescales sadly aren't quick enough for the types of work that we're doing that needs a decision today, next week. So I would dearly love to be able to take that robust hierarchy of evidence and focus on the very top and the very best that we can possibly get, but sadly in many cases it's simply, or the vast majority if not all cases, it's simply not there. And when you look for articles, you're going to be looking for things, you know, if you had it published this year, it was probably submitted a couple of years ago. Things move on so quickly, so I could speak for so much longer about the criteria, and absolutely I would love to say no, disregard blogs, they're total nonsense, but in the absence of anything else, let's find that those people who are working on similar projects. Let's learn before, learn during and learn after.
So thank you, Andrew. And of course within that hierarchy evidence, expert opinion does feature. And Rob, I'm going to come to you in terms of a question regarding the 10 in 10 support. And if Kay was here, I'd put the same question to Kay. So both yourself and Kay have talked about methods or innovative ways of translating knowledge to support clinical decision making within healthcare. And if we hold a mirror up then to guideline development, so guideline development, which sometimes gets labelled as a bit slow, sometimes not representative, can take a long time to develop and not updated quickly enough. Do you think if we put a group of the appropriate stakeholders in the room and ask them to make some recommendations on good practice, do you think that would look too different to this fully robust, fully developed clinical practice guideline that may come out from some of the guideline producing agencies?
I think you've framed the question probably well enough, with enough caveats there for me to say yes, because of the use of the term appropriate stakeholders in the same room. Because for me, the appropriate stakeholders in that room are the same people that should be involved in, say, NICE, for example. And the big difference between the two would be the bureaucracy, which, you know, it's neither a positive nor a negative word, but the red tape that and you know, going back to what Andrea said, just how long things take in research, that's the same when it comes to large organizations putting out mass communication. Things just take time. And I think if you put all those appropriate stakeholders in a room, I don't think it would be too far away from the end point that, say, something like NICE would come out with. Although, you know, I have often been surprised with sometimes some of the things that NICE come out with. So for me, I think it would be the next best thing in the absence of those high quality RCTs, those high quality systematic reviews, and those sort of rigorous processes within which decisions are made to create guidelines. So a long-winded answer, and the short version would be yes. I think they'd be similar.
Thanks, Robin. So apologies to those on the call if I'm not able to get to your question on the Q&A, but as mentioned, we will be developing a Q&A document off the back of this, which we will share. And apologies for running a little bit over. It was really important to give the speakers opportunity to answer some of the questions as we went along, but mindful that's left us a little bit tight at the end for the Q&A. So my apologies for that. So just to say thank you again for joining us for this webinar. We have another series of webinars lined up as part of our Connect Health Change series, with the next one being next month on the 10th of February. The topic is education and how education is the passport to the future. This will be chaired by Ash James, and we look forward to seeing you there. So thank you for joining, and we'll end the webinar there for today. Thank you very much.